I mean, not like full repair, but a little chip you can repair. A little chip from a metal ceramic crown you can repair using these bonding agents. So this MDP works on the concept of adhesion decalcification concept. So how it works is basically this decalcifies a bit of enamel and dentin and then adheres to it. The only drawback of this is sometimes that decalcification and calcification product that forms denatures. But with MDP, it doesn't happen that much. So that's why the bonding agents which contain 10 MDP are fantastic and they work very well. There is very less post-operative sensitivity with these because they kind of close those dentinal pores. And also it has been seen that once you're using these chemicals, there is an acid-base resistant zone that forms. So basically what it does, it reduces the chances of secondary caries. So, I mean, I'm very happy with this bonding agent. So it is the 3M universal bond, Scotch Bond universal bond. It's a all-in-one etchant, primer, adhesive, and bond. You can use whatever works again, but I mean, if you can, then use this. It's pretty good in terms of the results that it is giving to me. You can also use this to bond your veneers using your Emax veneers to bond to the tooth, because this also contains silane. So it is a single step bottle and it kind of gives good results and good bonding strengths to all the substrates. The question 4 was how do I establish the contact area when I'm doing composites? So again, it's a tricky, I mean, it again all depends on your adjacent tooth as well. So if your adjacent tooth, when you are preparing your class 2 composites or you are preparing your class 4 composites and you ditch the adjacent tooth, then getting the contact is very difficult, whatever you are using. So if I'm assuming that my adjacent tooth is completely healthy, what you can use, if it is only a mesial or a distal box, then I can use a sectional matrix. There are so many available in the market. I generally use Dentsply Auto Matrix as my choice of matrix for all the cases when I'm doing class 2. So what I generally do is always use a wedge, and you cannot use just any wedge. You have to choose the correct size of wedge that will just go into your gingival embrasure. Press your band against the tooth. If you use a very big wedge, your contact will be open. If you use a very small wedge, you will have overhang restorations. So you will have to see which wedge is the exact size. So that's why you have so many sizes available in wedges. You can contour your wedge a little bit in case you want to, if you feel the wedge is right size, but a little bit, not correct, you can contour your wedge. And always take a burnisher, and that's what I do. And then just press it against the adjacent tooth and run it like 4 or 5 times. So you'll get a concave kind of bulge in your matrix band, which will help in giving you an excellent contact when you are doing your composites. And also if you're using a slightly bigger wedge, you will have the tooth pushed a little bit apart. So as soon as you remove your wedge, the teeth come back and the contact is established. It's again, the more you do it, the better you get at it. But Dentsply Auto Matrix works pretty good. It's a very small, convenient matrix band system, which you can use. But you can also use the Pelodent, the sectional matrix system that also works pretty good. So it's a bit of an hassle to put that. But if you get good at it, it takes like a couple of minutes to put that Pelodent sectional matrix, and it works again very nicely and gives you good contacts and good curves around the mesial and distal line angles. Also, sorry, the buccal and the lingual line angles. Am I clear, Dr. Abdullah?
Yes, you are very clear, both on Facebook
right.
and Zoom. Okay.
Perfect. Question 4 or question 5 was shade selection in composites. Now, I mean, you would have seen multiple webinars, multiple talks. You would have attended multiple lectures on layering. So again, layering is fantastic, but then it takes a lot of time. It takes a lot of patience to do it. You need to have a lot of inventory into your clinic. And then we get demotivated. We feel, I don't have stains. And then, these guys are using stains and then only I can get a good result. or I don't have an enamel, I don't have a dentin shade, I don't have a translucent shade. So I mean, it's an investment, it's a technique that you will have to learn, but that doesn't mean that you really need to have all of that to give a good result. I'll show you this case. Why I put this picture was just because of this. So if you look at it, I mean, I did a composite buildup on tooth number 10, tooth number 9, and tooth number 8. All had mesial and distal caries. And we kind of did this with only one shade. So whenever you are doing your composites, please have a shade B2 and shade A2 with your inventory. When you have B2 and A2 in your box, 90% of your cases, if you polish well, if you give good line angles, your shade is going to match at human distance. Okay, not everybody goes in your mouth and looks. I'm not saying to do low grade dentistry. You need to do everything perfectly. It's just that the shade matching. So I mean, yes, if your tooth has fluorosis, you will need stains. If your adjacent tooth is like completely off, then you will need all those shades. You can match very good with simple basic shades. You can have 1 or 2 enamel shades, 1 or 2 dentin shades, but B2 is a shade that matches with 90% of your cases in the mouth. So have a B2, and Tokiyama B2 is fantastic. It matches with most of your teeth. So that's how I do my shade selection in composites. It's not like because I know when the patient comes in, I have like 4 patients waiting, maybe not waiting, but appointments are there. And I cannot spend 2 hours in doing one composite. And if I am doing so much of layering, I need to have those kind of trained assistants who can give me material in my hand. And there are so many other things. So even with a B2 shade, single or B2 and B1 combined, you'll be able to do most of your composites, anterior or posterior. So the shades that I have with me in my clinic are B2, A2, B1, A1, and A3.5 and A3. These are the basic 4 or 5 shades, and they really match with almost all the teeth. And the moment you give good line angles, you are able to do a good polishing. You have to have a good polishing system, and you will have a good result. So it doesn't really matter, don't get stressed about having a dentin layer, enamel layer, layering, having the mammalions build up. I mean, it looks good on a photograph. It looks nice if you are recording it, but then clinically, if it is possible in every case, it will take probably a lot of time. Question 6 was on flowable composites, when to use it. So my flowable composites is very limited use I use. The main areas where I use my flowable composites is probably as a very thin liner in a very deep cavity. That too, it will not extend to my edge. It will just be limited to the center portion of it, because I know the strength of flowable composite is not that much. That is one area where I use my flowable composites. Very small class 3 in anteriors, you can use flowable composite, doesn't matter. The recent flowable composites, they claim that the strength is very nice and you can use it as a full class 1, class 2 composites. I haven't used it. I still am using the packable composite, but I mean, if a company promotes that, and if you find it worth doing it, I mean, you can use it. But in my practice, I generally use flowable as a very thin liner. Probably after doing a full composite restoration, I will take a little bit flowable and run it on the occlusal surface, just in case to close any gaps that are formed. Class 3 composites, very rarely in class 5, because when you're doing a class 5 restoration, the flowable tends to flow out of your cervical abrasion. Then polishing becomes a little difficult. So very rarely in class 5, very small class 3s, as a liner in class 1 and class 2. And also I am very much using my flowable when I'm doing my veneers. So to repair my temporaries, to patch up my temporaries, flowable composite is fantastic. So if you're even doing a single crown and you feel the margin is just a little short in your temporary, you can just take some flowable, dry the tooth, put it in take a little bit flowable in the crown, press it, cure it, take it out, and your margins will be refined. So that is the area where I use my flowable the maximum in my veneer cases when I'm repairing my provisionals. I don't use flowable composites as a resin cement. Never do that, because the consistency of flowable is very high. Even if you heat it, it is generally not suitable to use it as a resin cement for your veneers. Question 7 was adaptation of composites. So, I mean, again, if your composite is of good quality, and if you have 3 or 4 basic instruments like Sculpt from Ivoclar, and even if you don't have that, you have basic plastic instruments, you can adapt your composite very well if your tooth is dry. So you can use something called as GC modeling liquid. So I have it with me in my practice. Sometimes only I use it for anteriors. So you can just take it on your brush, 1 drop of it, just put it on a tissue to take off the excess material, and you can use this to mold your composites and adapt your composites better. But generally you won't need it. I mean, if you have got good, small, sharp instruments, you can just use that to adapt your composites nicely to the cavity walls, as well as you can do your carving, your cusp carving or your anterior line angle carvings with that. But GC modeling liquid is a good buy if you want to invest into something that will help you in adaptation of your composites. So that will be nice. Question 8 was discoloration of composites. So, I mean, again, composites have got an inherent tendency of getting discolored. Whichever composite you use, eventually after a few years in service, it is going to stain a little bit. So there is no foolproof method of preventing a composite from discoloration. Anterior composite, the more you polish it, the more bigger your bevel it, the more better the adaptation, the less chances of it being discolored. So whenever you are doing an anterior composite, make sure that you have given a really nice bevel so that you have a no unsupported enamel. That is one thing. Polishing is very, very, very important. So you should have the composite polishing burrs as well as the super snap or any polishing discs to kind of do a really good polish and never skip a step. So if the Soflex disc has got 4 discs, you have to use all 4. You cannot use the coarse one and then jump on to the extra fine one. You won't get that polish that is required. So when you are doing it, the only way to prevent discoloration is to have a really good polish. Also, don't use bonding agent as your last coat, because it might look shiny on day 1, but the bonding agent kind of weakens your composite eventually, and it will cause more staining on a later term. So don't get your polish by putting a layer of bonding agent or your adhesive in the end. It might be looking very shiny, but eventually it is going to stain more. So have a good adaptation, use good quality material, have a good bevel in anteriors only. Posteriors, you cannot give a bevel. The composite is going to fracture. So only in anteriors, give a good bevel and polish them nicely. So the more you polish it, the less it will stain. And finally, patient instruction always. So tell the patient not to consume a lot of colored food. And every 6 months when the patient probably comes for a prophylaxis or a scaling, just polish those restorations again. Most of the stains which are superficial will generally go away. So that's how generally I prevent discoloration of composites, but you cannot completely not have discoloration in composites. That's why Emax veneers are generally preferred over your composite veneers, because composite veneers eventually wear and stain. That's the drawback of composite restorations. Question 9, how do I establish a class 4 composite proximal surface? Again, there are many matrix systems available in the market. There's something called as BioClear matrix system, which I've seen videos of it. It is just a curved, clear matrix band to help you give the proximal surface. But again, not everyone has everything. Even I don't have it. So how I do it is basically to have a clear polythene sheet or a mylar strip. I put it, have a good wedge, and then I always overbuild it. So you need to overbuild your tooth a little bit, and then if you have underbuilt it, it will not look good. So always have a slightly overbuilt tooth and then have a proper set of burrs to shape your tooth properly. But again, adaptation using a wedge is good. Adaptation with your mylar strip is going to help you in getting a good proximal surface on your composite. The third technique to have, if you are missing a palatal wall, you can ask the lab to do a wax up for your fractured tooth, and you can make an index in the clinic, put it behind the tooth, and adapt your composite on it to have your parietal ball built first. So, I mean, those are the things that you can do. If you can invest in BioClear matrix system, it is fantastic. I've seen good results with that. But even with mylar strips, you will still have fantastic results on your proximal surfaces of your class 4 restorations. Question 10 was postoperative pain in composites. So I have told you already, the bonding agent is important. The incremental curing is important. So if you have a deep class 2 cavity and you have used again, matrix band with a wedge is important. The moment you put in the wedge, you will realize that there is the gingival fluid is not seeping into your cavity from below. But if you don't put a wedge, 5 seconds later, you will see there's a pool of gingival fluid in your pulpal floor. And then if you pack your composite on that, you are eventually going to have sensitivity. The light is very important. So when you have a curing light, you should know that it is working properly. It is not very strong and it is not very weak. A very strong light will eventually just cure the composite very quickly, causing it to shrink more. Whereas a very weak light will eventually not cure your composite. So get your light tested. It should be around in 1200 range. The MDP, the bonding agent that I'm using right now has got 10 MDP, which again causes a bit of reduction in your post-operative sensitivity in composites. So have a dry field when you are putting in composites, incremental technique, use an excellent bonding agent. You can use a product like Gluma, but Gluma is not so readily available. So the best way would be to have a really good dry field of work and use selective etch. Don't use complete etch, because the moment you use complete etch, the smear layer on dentin is also dissolved. And then the pores get open more. And if your filling is a deep filling, you will eventually end up in post-operative sensitivity. And finally, when you are doing your occlusion, please make sure that you don't have any interferences. You don't have any high points. Ask the patient to do chewing. Put an articulating paper and ask the patient to chew it like a chewing gum. There is no point in asking the patient from movement from in to out like we generally do. So what we do is we put in the paper and we ask the patient, okay, bite. You go left, then you go right. So that's not the right way to do it. The right way to do is put an articulating paper and ask the patient to chew it like a chewing gum. Then you are able to get better contacts. And then any contact which is on the non-functional cusps, please remove it. Don't have your contact points on the margin of your restoration and tooth. So whenever you are doing a composite restoration, before you start a restoration, take an articulating paper, ask the patient to bite, see wherever the occlusal points are coming. Either you include those points in your restoration or you're going to stay away from those areas. So the moment you do that, lesser the chances of post-operative pain in composites. So those are the main things, I mean, that will kind of, but still, sometimes you do everything and the patient will come with pain. So that is definitely there. Not all the patients will be pain-free after doing restoration. So then always tell the patient that there is a possibility of having some sensitivity for a couple of days after the procedure is done. That's ought to happen. Question number 11 was on diastema closure. Dr. Abdullah, what was the question exactly?
Just a second.
Yes.
It was question 11. What is the best technique? What is the best technique of diastema closure?
So again, when you have a diastema, it all depends on, you need to first diagnose it, why you are having a diastema. So if it is tooth size arch length discrepancy, then there is some different treatment. If there is a mesiodense, there is a treatment plan that differs completely. If there is a very thick high frenal attachment, the treatment plan differs. So I'm assuming a case where there is no mesiodense, the frenum has been corrected, the orthodontic alignment of teeth is fantastic, and only the patient complains of a midline diastema, which is not, if a midline diastema is more than 3 to 4 millimeters wide, if you do composite buildup or you kind of do veneers, there is a high chance of having papillar inflammation, because that's a lot of compression that is going to happen. So in those cases, what I would generally do is I would go refer the case to the orthodontist, get the spaces distributed equally, and then do 4 veneers. So I will have better proportions of my teeth, better looking teeth. But if your diastema is 3 to 4, 5 millimeters, then, and if you're doing, so the best way to do is by doing Emax veneers, because they give you the most stable result. And a guideline here, when you are doing a diastema case and when you are preparing your margins for your veneers, just make sure that wherever there is a diastema, try to go subgingival in that area. So when you're when you're putting your margin for your veneer, in the area where there is spacing, just tuck in your margin a little bit subgingival. So when your veneer is going to come, it is going to compress your papilla and you will have a fantastic papilla fill. But if you are doing your diastema cases with composites, make sure you don't have any overhanging ledge near the papilla, because that will ultimately end up in a severe gingival inflammation. The best way to do is again will be by Emax veneers, but again composite also in good hands can do wonders. An endodontist did a diastema closure for my father 15 years back, and it is still functioning. So I'm not saying that veneers is a better option, but then it's more predictable and a more long-lasting treatment option when compared to composite. Less staining, less worry, less reduction on the tooth because you already have a space there. So yeah, that's about the diastema closure. Question number 12 was on bulk fill composites. So the bulk fill composites are comparatively newer composites. I'm not saying very new, but comparatively newer composites. And I would not use it generally for my restorations. I can use it for my core buildups in my non-vital teeth. The reason is, one, they have got a higher translucency. Why? Because we want the light to penetrate deeper. That's why these the bulk fill composites will not look so natural when you are doing a filling. So the bulk fill composites generally have got a higher translucency. They have got a lower strength because the filler content is low, again for the fact that the light has to penetrate deeper, and they need slightly more time for curing it. So one way they say that they save a little bit of time, but eventually you have to cure them for a slightly longer period of time than your normal composites. Companies will claim many things, and 90% of things will be true, but again, please do it before you come on to a conclusion. So bulk fill, just I limit it for my core buildups if at all. But even for my core buildups, I use a very high quality composite. I want it to bond nicely and have a good strength in my core. Question number 13 was onlay cementation protocol. So the protocol that I use is I'm generally, when I'm doing an onlay, it is Emax. So it's a glass-based ceramic, either lithium disilicate mostly. And the protocol for me is to etch the onlay with hydrofluoric acid for 20 seconds. So the onlay gets etched with hydrofluoric acid. The tooth gets etched with the phosphoric acid. 20 seconds is the onlay, 40 seconds is my tooth. I wash both of them. I have my universal bond. I will apply it on the tooth, dry it, but I will not cure it. I will apply the same bonding agent on my onlay, dry it, but no curing it. Use my Rely X veneer cement from 3M, put it onto the tooth, cure it for 2 seconds, remove the excess, because just for 2 seconds, the excess will come out very easily. Then I cure it properly for 40 seconds in all the areas, correct the occlusion, and then finally we polish it with the polishing burrs. So that's generally the onlay or veneer or inlay cementation protocol. Anything with Emax, the protocol remains the same. So whether it is an onlay, single inlay, or a 10 veneer case, it goes like this. All right. Question number 14 was again on pizza technique. I have already told you. I mean, it's just a technique of putting in composites and to reduce your C factor. And any method that reduces the C factor will give you a good composite, less chances of micro leakage happening, and less chances of those white line around your composite filling. Sometimes you see that. Sometimes when we cure the composite and we see a white line all around our composite, that mainly happens because of the shrinkage that has happened. So try to limit that shrinkage. Pizza technique is just using composite to build each cusp individually. So that's generally the technique for the, I've already discussed that as my first question. Oblique technique, again, I've discussed it in my first question. So nothing much in that. Question number 16 was on pulp exposures and composites. Now, this is a good topic to have a discussion on. There are many materials that are available. Whether we should first do pulp capping in adult teeth, that is question number 1. Of course, we can do it. Chances of success are very high if done properly and the proper technique is followed. And what material we should use? So there are multiple materials that you can actually use. The old and the gold standard against which all the materials are compared is calcium hydroxide. So you have a calcium hydroxide quick setting. You take, so I've seen many times patients have come to me where the calcium hydroxide is filled in like a base, which is extending to the margin. So never do that, because calcium hydroxide is very soluble. If you have put a very thick layer of calcium hydroxide and you have covered the whole dentin, then you are ultimately reducing the surface available for your bonding. Take just a tiny drop of calcium hydroxide, put it where the cavity is the deepest. That's all. You don't need to paint the whole tooth with calcium hydroxide. Make sure that it doesn't extend beyond your margins anywhere, because those areas will ultimately provide the leakage. And also it has been seen with calcium hydroxide is the recalcification or the remineralization that happens with calcium hydroxide is not great. There's always some tunnel-like defects, so that the remineralization is not complete. So after 3 to 4 weeks or 6 weeks, when you re-enter the tooth, you will not see a good remineralization. So calcium hydroxide is not considered as a material of choice for direct pulp capping these days. And I would, if it is a direct pulp capping, I would never do the composite on that day. So I would clean the tooth, put calcium hydroxide, put a good temporary sealing material, leave it for at least 6 weeks to 8 weeks, and then evaluate for remineralization. If I feel that there is a bit of remineralization that has happened, then only I go back into the tooth. Otherwise, we leave it for some more time. So calcium hydroxide, a good material. MTA is a good material, mineral trioxide aggregate, but the manipulation is a bit difficult. Also, you have grayish discoloration sometimes. So it will be difficult for it to be used. Biodentin is a newer material, slightly expensive, but it is very biocompatible. And the remineralization that is seen with biodentin is fantastic. There is no tunnel defect seen, and you get really good remineralization barrier formed. So biodentin is a good material for pulp exposures. And finally, the light cure MTA, a newer material that has come. I have not read much literature on it, but there is a lot of good literature on this. But if I have to use in my clinic, I will either use calcium hydroxide or biodentin for my pulp capping. So that's what about pulp exposure and composites. Dr. Abdullah, is there any doubt till now? I continue.
Yes, everything is clear. I just muting the loud. Just
okay.
A moment. Okay. Go on. It's all clear.
Okay. Question number 17 was, how do we differentiate between affected and infected dentin? See, I am very happy with these questions because some of the questions can be asked in your membership exam as well. So these are good questions that were asked, and I'm really glad that these questions were actually put across. So, how do you differentiate between affected and mineralized denatured dentin, which is completely waste? It is completely of no use, so that has to be removed fully. The affected dentin, though it is demineralized, but it has got intact collagen and it is remineralizable. So if you take care of it, it can remineralize and can act like a barrier. The best way to do it is by using any caries detection solutions like propylene glycol with dyes. What this does is basically it will stain the infected dentin and not stain the affected dentin. Even by this, sometimes it becomes very difficult. So the visual feel of affected dentin is infected is very soft. It comes out like butter if you use a spoon excavator. Whereas the affected dentin will not be so easily scrapable. So whenever you reach that zone where it is not easily scrapable or you feel it is like hard, just leave that. You can leave that. The bonding is a little weaker in affected dentin, but still, so that's why it is very important to have your margin of your restoration in clean, non-demineralized, non-affected dentin. The margins preferably should be in good supported enamel. That's what we generally want. Sometimes in deep class 2s, there is no enamel left. Make sure that the edge is very clean. So that is very important, but there is no sure shot way of, okay, this is affected and this is infected. There is no demarcation as such. So it's more of tactile visual, and these dyes are going to help you in differentiating the affected and the infected dentin. Cavity and chlorhexidine. So I read an article.
Excuse me, doctor.
Yes.
Sorry for interrupting. I just had received a question about that previous one, which is which one is easy to remove, affected or infected dentin?
Infected dentin is easy to remove. Infected dentin is easy to remove. Infected is like butter. It will just, if you just scrape it with an instrument, it will come out. So infected dentin is very easy to remove. Affected dentin is slightly difficult to remove. It's slightly more harder than your infected dentin because it is still intact.
Okay, doctor, thank you. You can complete.
So the cavity and chlorhexidine. Now the cavity and chlorhexidine, I recently read an article. So 2% chlorhexidine is good. You can use it in cavities, deep cavities. Take a cotton pellet, you dip it in chlorhexidine, leave it in the tooth, and then you need to wash it properly. There is generally no change in the adhesive strength, but don't overuse it. So don't use it for a very long time because eventually that might cause a problem in your smear layer. So you can always use it. It can clear off some bacteria, but it will not affect your bonding. So any deep cavity, you can always use a cotton pellet dipped in chlorhexidine to clean your cavity a little bit. Oh, this was a long question. The 19th one was file and apex length. So how do I know if my file has reached my apex? So I mean, it's a full endodontic topic to be discussed. I am prosthodontist, but I do root canal. So I'll just give you a rough idea of how I make sure about that. So the things that we use currently are apex locators. The one that I use currently is the ratio type, that is the root ZX2. So this is the apex locator that I have in the clinic that I work in. There is these 6 classes or the 6 grades or generations of your apex locators. They all work on the principle. Basic principle is that the closer you reach the apex, the beep is going to come in. They work on different principles. They each have got their own drawbacks. Some need very dry field of working. Some of them will not work in cases where there is pus coming out. Some of them will not work if they are not calibrated to each tooth, each patient. So all of them have got different drawbacks. If I start discussing these, it's going to take 1 hour just to discuss the apex locators. But apex locators are fantastic. The root ZX2 has got a very good clinical application, and most of the time it works very well, even if the canal is slightly weeping. I'm not saying it shouldn't be like oozing out with pus, then these won't work. But in 99% of your cases, the apex locators work nicely. And always before you obturate it, you will always take a master cone IOPA just to know if your GP is reaching your apex. So those are the 2 ways, by a radiograph or by using the apex locators, you can come to a conclusion whether your file has reached the apex or not. Question number 20 was teeth with pus. So I mean, teeth with pus for doing a root canal. So the first line is you have to open the access. The moment you will open the access, the tooth should start oozing out pus. If not, then establish the working length. With a 15 number file, you can go beyond the apex a little bit, which will cause the pus to drain. So whenever I have a case with a tooth with an abscess, active abscess, I would clean it. I would use all the sodium hypochlorite, 5% as my irrigation, then saline, then sodium hypochlorite, and then saline in the order. Never use hypochlorite and chlorhexidine as your two irrigants used together, because the moment you use chlorhexidine and sodium hypochlorite is there in the canal, it will form like a product which will stick onto your dentin walls. Then that makes it difficult for the smear layer to be cleared off. So I do irrigation. I keep using paper points, and then I put a calcium hydroxide paste in the canal, and we leave always I send the patient with a closed dressing. The open, I mean, some endodontists prefer giving an open dressing. Some are completely like closed dressing. I am the person with closed dressings. So clean it nicely, put a calcium hydroxide dressing in the canal, and you can close it with an temporary filling. Tell the patient that there might be a flare up. Patient might have to come to the clinic, and you have to repeat this step maybe 1, 2, 3 times based on the pus from the canal. The moment you are having a paper point which is completely dry, you can obturate. So that's the general treatment plan with a tooth with a pus. Granuloma in pus, again, I mean, granuloma is just a periapical cyst with a tooth. I mean, generally a chronic condition. Patient might not have any symptom. It might be an asymptomatic tooth. When you open the pulp might be necrotic, but there might not be any active pus in it, because generally it has turned chronic. You will, on a radiograph, you will be able to see a periapical cyst, whereas a very active fresh lesion, you will have probably no radiographic changes. But as soon as you open the tooth, the nerve will be necrotic. I mean, the pulp will be necrotic, and there will be pus coming out. And generally a tooth with active infection is more having clinical symptoms, whereas a tooth with a periapical cyst might not have any clinical symptoms, and you might just discover a tooth on a chance on a radiograph when you are doing some other checkup for the patient. This question was completely, I don't know what exactly was asked in this question, so we are going to skip this question, primary and primary. I really didn't get this question, so we just skip that off the table. Flowable composite I have already discussed when I use and when I generally don't like to use them. Camera choice. Now, what camera I use and what camera you should use. See, again, it's what works in your hand. Everything. I am a Nikon person, so I have a Nikon camera. I don't have a full frame camera. I have a cropped sensor camera. So it doesn't matter what you use. You should start taking records is what it matters more. Taking proper records is the second step, wherein you know that, okay, this is the angle I have to take my frontal photo. This is the angle I have to take my lateral photo. That is the second stage of learning. You can use your mobile phone also. You can use a point and shoot camera. You might not get the best pictures, but they will still be providing you a lot of information that you need. But to have really good quality pictures, you need to have an SLR camera. Then the choice is endless. There is mirrorless cameras, there are mirror cameras, there is full frame sensor cameras, there is cropped sensor cameras. So there are so many. I'll tell you what I use. I use a Nikon 7100. It's a cropped sensor camera. It's not a full frame, but it gives excellent results. I'll show you a couple of pictures in the end to just tell you like what kind of photos you can get with that camera itself. Of course, if I have a full frame camera, the quality of the pictures is going to be much better, especially when I crop them. So so the camera choice, the main thing is start taking pictures. A lot of times we are thinking we don't have the equipment to take the photos. That's why we will not take it. But that's not right. You know, everybody has got a phone these days. Everybody has got a really good quality phone with them. The cameras in these phones are fantastic. I mean, you can take a good picture without even a flash as well. So start taking pictures. The more you do it, the more better you get at it. How do we do shade selection value based? So I mean, generally, when I do my shade selection, my shade A1, B1, A2, B2, not like that. So you can take a screenshot of this, or probably it's there on my Instagram as well. But this is the value-based shade arrangement of your shade guide. And once you have this, it will be much easier for you to have a shade selection. You will be much closer to the shade. And always when you are doing your shade selection, one, you will have to have a light source which is correct. That is, it should match with the daylight as much as possible. Thirdly, you can squint a little bit and also do your value-based selection. So this is very important. Your shade guide should generally be arranged in this manner, and it's going to help you quite a bit in your shade selection. So you have the shade tab arranged from the lightest to the darkest. That's a value-based arrangement of your shade guide. Shade matching in Diastema, it is, I mean, not a specifically different question than what we have discussed. Again, the more number of composites you have, the more difficult it will be to have a shade match. So my idea is always to have minimal equipment. B2, A2 shades are the maximum that you are going to use. And if you have a good composite micro hybrid or a nano hybrid, you will have a really good polishability of that as well. Post-operative sensitivity in veneers, ideally it shouldn't be there, because ideally your veneer preps should be limited to enamel. So most of the time when I do my veneer preps, and if it's a fresh case, I will do the prep without anesthesia. So I know that my preps are in enamel. Unless there is a tooth that is slightly outside of the arch and I have to bring it in, then yes, of course I have to give anesthesia. I won't be a butcher there. But most of my veneer preps are without anesthesia. So you know you are limiting yourself to enamel. If you're using a good cement and if you have used a good lab, the adaptation is so good and the cement and the bonding agent is so good that ideally you shouldn't have any post-operative sensitivity. If by chance you have post-operative sensitivity with veneers, then you can either go for something like a Gluma desensitizer just to close the areas that are open, or look for areas which have got a leakage. Then my suggestion would be to change that veneer, or before you even cement the veneer, just sure that your fit of the veneers is good. So ideally there shouldn't be any post-operative sensitivity with a nicely done veneer case. Best technique to replace composite. How do we differentiate composite and tooth? First is why you have to replace a composite. Just because it doesn't look good doesn't mean that you should replace a composite. Sometimes a filling in a posterior is nicely bonded and patient doesn't have any complaint. You take an IOPI, you don't really see any secondary caries, but just because you feel that, you feel a stained composite, you'll be like, oh, let's change it. But that shouldn't be the case. So there should be a reason for you to change the composite. And trust me, if you have that reason, there will be no problem in identifying composite from tooth. Because if you have a secondary caries, if you have a micro leakage, the moment you start removing the composite, there will come a time when the whole chunk of composite will just come out. So ideally, that composite should be changed only if there is a symptom. If there is a crack of the tooth, probably a crack of an old composite, it's very rare that you will not be able to differentiate a composite from a tooth. And eventually, whatever best magnification you have, little bit tooth will be damaged, a little bit. So don't really worry about it much. Try to be as minimal as possible. Try to be as controlled as possible. And if it is a poor composite, you can definitely make out tooth from composite. Different flashes. I have a soft box, or I have a twin flash, or I have a ring flash, or I have the Canon ring flash, or I have the R1C1 kit, which is the twin flash system. See, the thing is, again, the more the amount of gadgets you have, the more you will be demotivated, because the more you will access. Start with mobile phones. Go on to a camera with an inbuilt flash. You will not get great photos, but you will get the hang of it. Then what I used initially was a R1C1 kit for Nikon. It has got two flashes attached to my lens. Okay. So those flashes are good. they gave fantastic results. But the problem with those flashes is it's attached to the camera. So the moment you move or the moment the patient moves, the light that falls on the teeth changes. So every time when I move or I go closer to the patient or I go above, I will have to quickly change the settings. So I have to be really good at changing those settings. So what I use right now, I'm having two separate flashes which are put on top of the patient from the side. And so the exposure that I have on my teeth is fixed. So if I move, if I go close, if I go far, the light that falls on the tooth is same. The camera will record the same exposure values of those pictures. So right now I'm using two flashes with two diffusers, and that's all that I have right now. And I have a Nikon 7100 camera with a macro 100 mm Nikon flash. So that's the 2-3 things that I have. Soft boxes are good if you have place in your clinic, because soft boxes are big. They will require some space for them to be stored. So if you have a big operatory, you can have soft boxes. But I have something called as magmods, which are like small silicone spheres that go on my flashes, and it gives nice diffused light. So I mean, yes, flashes can be anything, but right now I'm using two flashes that are separate and on tripods. Endodontic sealers, a very big topic again. Which one is better? Bioceramic sealers. I mean, what I use currently is bioceramic sealers because they are very biocompatible, though they are very expensive compared to the other sealers. Even resin sealers are fantastic. Calcium hydroxide based sealers are generally not recommended because some patients are sensitive to it. And it has been seen that calcium hydroxide based sealers can give post-operative pain after obturation. So bioceramic sealer or resin based sealers are excellent with warm condensation of your gutta percha. So that's generally what is recommended. Composite buildup changes in dimension. So, I mean, of course, any composite material that you have has got a dimensional change. It can be up to 2% shrinkage. So what is generally recommended is again a layered build-up technique. You can use the oblique technique, you can use the pizza technique, you can use the burger technique, whatever sandwich technique, whatever food that comes into your mind, you can make a technique out of it. But the main concept of it is that you minimize the number of bonded surface to the unbonded surface and have a layered incremental curing, have a proper curing light with a proper intensity, choose a good bonding agent, have a dry field of work, and that's all. I mean, if you have these things in mind, none of your composite is going to fail. So that's what is more important. Remove pulp before veneer? No, why? Never. I mean, even when I do full crowns, and if I'm doing elective crowns like for a full mouth rehabilitation, I would not do a root canal. It is never recommended to do a root canal for a crown prep unless deemed necessary. Deemed necessary means if a tooth is supra-erupted and you have to do a crown and you know that you have to push it up or push it down, we do a root canal. But not just because I have to do a crown on a tooth, I would not do a root canal. Or just because I have to do a veneer on the tooth, why would I do a root canal? So never do a root canal for a tooth where you have to do a veneer unless the tooth is like very much outside and you have to bring it in the arch. Yes, then you have to probably do it. Still go for orthodontics as an option to bring the tooth a little in so that you don't have to do a root canal for a tooth, because I mean, nothing happens, but it's just that, you know, you are killing a good healthy tooth and taking the stage to the next stage of tooth's life. So never ever, I mean, we do this. Ideal veneer preparation. So the ideal veneer preparation, what generally I do, I'll just quickly, I mean, show you. One second. You want to see a veneer prep? Let me just find out a case where I have prep tooth. Sorry, I know where is it. Yes. So if you ask me what an ideal veneer prep looks like, I mean something like this. So I generally like to have a bud joint incisally. There is never a palatal overlap. You don't really need that. So you have an incisal bud joint. The finish line should be minimal, but there should always be a finish line. I generally don't prefer prepless veneers because you'll ultimately end up with bulky veneers. And the preparation should be very well polished. It should actually be more polished than what you see in this picture. So, but the more you polish it, the more smoother the line angles and the edges are, the better you are going to have the adaptation of your veneer. So the ideal preparation is having a single path of insertion, an incisal butt joint, a chamfer margin, supragingival in most of my cases, except I have told you in a diastema case like this here, you can see I have pushed my margin a little subgingival because there is a diastema here. So I would want my veneer to compress this papilla here. So subgingival only in cases where there is diastema. Otherwise, in most of the cases, I would go for a supragingival margin preparation. So that's generally what is about the ideal veneer preparation. Chlorhexidine in endodontics, it's a good irrigation solution, but there are a couple of things that you should be remembering. One, never use it together with sodium hypochlorite. You will end up with products formed which are not great. So if you are using chlorhexidine, it should always be used after saline. And then after chlorhexidine, you will use saline before you go on to sodium hypochlorite. It is antibacterial, but it doesn't remove all the bacteria. It doesn't remove the smear layer, and it doesn't clean the tooth that much. So chlorhexidine cannot be your only irrigation solution. It can be an aid, it can be an addition to your armamentarium, but never a only irrigation solution. 5% sodium hypochlorite and saline, you need it for proper irrigation. So chlorhexidine with endodontics is a good irrigation, but not the only irrigation that should be used. I think the last question is already answered. Remove pulp before veneer? No, never. You will never do that.
Excuse me, doctor.
Yes.
Sorry, go on. Sorry, complete.
Yes, so I mean, I've already told this. So there shouldn't be any removal of pulp. I mean, or you should not do an intentional root canal before you do a crown or a veneer unless required.
Okay, so I know that you have. Sorry, I know that you have a limited time, but I have received a few questions during the live session. Can we answer a few of them?
Of course I can. I have around 20-30 minutes more. I mean, before we do that, I mean, this is my Instagram page. So I am on Instagram, and anybody has got any questions, they can shoot them there. I will answer them, and mostly I am quite available on Instagram and help people around. So if anyone need any questions on exams or, you know, dentistry or generally anything, I mean, I would be happy to see more number of followers here. So please do follow me on Instagram, and I'm there to help you out with anything. So any questions?
Yes, but before the questions, I just wanted to speak about the Instagram account in Arabic. شباب, حساب الدكتور على الانستغرام يجاوب على اي اسئله او استفسارات تكون عندكم بخصوص restorative dentistry. ممكن ان تتابعوه. I just spoke about the Instagram account. Okay. So now, first question is from Dr. Nama Hussein. She's asking, can we clinically differentiate between affected and unaffected dentin? Clinical differentiation.
Clinical differentiation, I've told you, I mean, just by looking at it, sometimes it is difficult, but if it is not shiny, if it is looking soft, if it is looking, you know, rough, then it is mostly infected dentin. And the best way to do is by tactile. So you take a spoon excavator and just run on it. If it is coming out like butter, it is probably infected dentin. But if you feel like a hard surface or a sound coming like a, you know, rubbing sound, then that is probably your affected dentin. But the dyes help quite a bit in differentiating between affected and infected dentin.
Okay, another question is, in every case of operative dentistry or restorative dentistry, I must use enamel and dentin shade, or I can use only one of them?
I have told you, in 90% of the cases, clinically, you can use only one shade, that is B2. You don't really need enamel dentin I mean, yes, they will give you fantastic results. They will give you picture perfect results, but it comes at a cost of inventory. It comes at a cost of your time. It comes, you cannot be charging, 100 dirhams for a filling and be using so many composites and investing 1 hour in one composite, right? So you have to see a thing, and I don't want you to think and look at those lectures and feel that I cannot do it if I don't have these things. So that is a very wrong thing. Even if you have good composites, have one enamel, one dentin shade, you'll be more than happy.
Okay, other question is about stopping the bleeding.
Okay.
Sorry. Sorry, can you hear me? Sorry, can you hear me now?
Yeah. Yeah, I can hear you.
Yes, another question. Yes, the other question is about stopping the bleeding protocol when we have a rubber dam and wedges. What can we do?
So the stopping the bleeding, generally the two things that I use. So generally when I'm doing any restoration, I am always giving a local anesthesia. So my soft tissue is also generally very, it's numb when I'm doing it. So when I'm putting my matrix band, and if I feel that a small portion of your gingiva is kind of getting caught between, or it's in the floor of my restoration, I will take a very small burnisher. I will just make it red hot and I will just scrape that tissue off. So that is basically called kind of a cautery, and we remove the tissue and automatically the bleeding will stop. That is one way of doing it. I mean, but make sure that the soft tissue is anesthetized. If you have lasers, you can use that as well. Thirdly, if it is just bleeding and you don't see any tissue, I have the aluminum chloride. It's hemostat. It's called viscostat clear. I can just put it there, leave it for around 5 minutes with a cotton pellet, and the bleeding stops in most of the cases. So these are the couple of things that I generally do to stop the bleeding from gingiva.
Okay, the other question is about when we have a class 2 restoration and the dental floss is not able to pass between the teeth. What is the protocol that we do for that?
See,
we have a bad contact area.
Yeah, you have a bad contact area. Then the only way to, there are a couple of things that you can do. So that means if the floss is not passing, that means there is a blocked contact. So then the simple polishing, the plastic polishing strips won't go in between also if the floss is not going. So the best way to do is to have a metal finishing strip. There are very good metal finishing strips available in the market. Also, there are saws that are available. You can kind of put a wedge first. The best way to do it is first to put a wedge, a thick wedge, and leave it for 3 to 4 minutes. What that will do is it will create a separation between the two teeth, and then probably even your plastic strip can go and you can polish it a little bit and correct your occlusal embrasures. So then you will have a better floss. But even if after putting the wedge, your plastic polishing strip is not going, then eventually you will either have to use a metal saw or a metal finishing strip to open the contact, and then wait and see. If then the food impaction is starting to happen, then eventually you'll have to either go for a inlay or an onlay, and that will give you a better contact.
The other question is, what is your opinion, doctor, about the using of chlorine in endodontic treatment?
Of using?
Chlorine, I think. I don't know what she means.
Chlorhexidine. It will be chlorhexidine only. It will be chlorhexidine.
Yes,
I've already told that. I've already told that.
Okay.
For endodontic, it cannot be your only irrigation. It can be an aid. It can be an addition. And never use it with sodium hypochlorite as your irrigants together. So there should always be saline in between.
Okay. The last question is, what about your opinion, doctor? Diluted sodium chloride by distilled water is better than normal saline. Agree or not? About your opinion. Do you agree with this?
Saline diluted with?
No. She's asking, washing with normal, with sodium chloride diluted by distilled water is better than washing with normal saline.
Doesn't make a difference. I mean, saline is salt and water only, right? So if you can mix salt and water and do it, but then the concentration will be different every time. So it's always better to have a standardized solution for your irrigation. So always have a 5% sodium hypochlorite as one irrigation and have normal saline. isotonic as your one irrigation, and you can have EDTA 17% as one of your irrigation. So generally, these are the 3 irrigants that I use. I generally don't use a chlorhexidine irrigation for my root canals. So if I am using proper sodium hypochlorite, and if I activate it properly, I'm able to clean the canals very nicely.
It was the last question. Thanks a lot,
Perfect.
doctor, for today. Thank you so much for that.
Thank you. Thank you. I hope it was, everybody had some benefit from it. And thanks once again. And we'll do a couple of these sessions again then soon.
We are so happy for that. Thank you so much, doctor, for what you did. Thanks a lot for your time.
Thank you.
Thank you. Goodbye.
Goodbye. Bye-bye.